So now we're going to talk about how much control the ventilator is going to have over the patient's respirations. So we can set the vent to control as much or as little of the patient's breathing as we choose. And this is called the mode, okay? So mode refers to how the machine will ventilate the patient in relation to their own respiratory effort, okay? There's lots of modes, and then there's several of them that can be used together. The one that has the most control is controlled ventilation. We don't really see that used that much because it delivers a preset volume or pressure regardless of the ability of the patient to breathe on their own. So this is used for people who are unable to initiate breath at all, okay? Um, and it's pretty much like automatic pilot. So you would determine what the oxygen, the amount of oxygen they receive, so whether it's, 50% or 100% oxygen, what the tidal volume is, okay, and then what the respiratory rate is, okay. It's used, controlled ventilation is preset, and it's for patients pretty much who are sedated or paralyzed, and that we don't really anticipate them coming off the ventilator. As I've said before, patients get very used to having the machine do the work of breathing for them. So the more control a ventilator has over the patient's respiratory effort, the more difficult it can be to wean them off the machine. Okay. The second most controlling mode of ventilation is assist control. So this one gives the patient a certain amount of control. It delivers a breath in response to the patient's effort. So if a patient tries to take a breath in themselves, it will deliver them a preset amount of air, okay, no matter how much effort they put forth. In other words, if I have a patient who just like takes a little teeny little breath in, okay, it will still give them a preset amount of oxygen, okay? It does that for a patient whether or not it's a little baby breath or it's a great big effort that they make, okay? So this assist control is usually used for people who are able to spontaneously breathe but have weakened muscles, okay? Now, assist control, what happens if the patient doesn't breathe? Well, if the machine recognizes that the patient isn't breathing, it's still going to deliver a certain amount of breaths per minute, okay? So it sort of goes a little bit like this. They'll set the machine, let's say the patient's getting 50% oxygen. The tidal volume is 600, okay? And they're going to get a respiratory rate of 16 breaths per minute. When you have assist control, the patient is going to get 16 breaths per minute no matter what. If the patient tries to breathe on their own, they will get another, let's say, a 17th breath, okay? If they do it 2, 3, or 4 times, their respiratory rate can be, up to 20, 25, 36, whatever. But every single time they try to initiate a breath, they're going to still get that full 600 milliliters of tidal volume at 50% oxygen. So you can see that sometimes these patients will sort of overbreathe the machine, and if the machine isn't set properly, the patient oftentimes can sort of breathe and breathe too much, okay? So sometimes we can have the patient have hyperventilation, okay? Synchronous intermittent mandatory ventilation, or SIMV, okay? This synchronizes breathing with what the patient's respiratory effort is, okay? So the patient has a preset volume of air that they're going to get no matter what. But this particular mode will let the patient receive air only in the amount that they can move on their own. So for example, if a patient takes that little teeny baby breath in, okay, they'll only get maybe, I don't know, 300 milliliters of air, okay? If they take another bigger breath, let's say they move 500 milliliters of air, they'll get the 500 milliliters of air, okay? And so each ventilator breath will be delivered in synchrony with the patient's breath, okay? The patient is allowed to completely control the spontaneous breaths that they take, okay? And it's very good. This particular mode is extremely good when you're trying to wean the patient because it will let the patient do as much as they can on their own, okay? Now, the disadvantage to this kind of breathing mode, the synchronous intermittent mandatory ventilation, or SIMV, is that sometimes the patients get tuckered out. So sometimes you'll see them use this while they're trying to wean a patient, and maybe they're weaning the patient during the day, and the patient sort of gets tired at night because they've been trying to keep up with this respiratory effort all day long. So patients do get tired when they're on SIMV. Pressure supported ventilation is giving the patient a preset amount of air that comes with a positive pressure. Okay, it sort of pushes air into the patient's lung. The patient is still controlling the respiratory rate and tidal volume, but it also will overcome the resistance of breathing through the ventilator circuits and the tubing. And then we have high frequency ventilation, and high frequency ventilation delivers small amounts of gas at a rapid rate, like at 60 to 100 breaths per minute. And this is used because sometimes one of the complications of ventilation is the patient becomes hemodynamically unstable. In other words, what happens is the patient begins to drop their blood pressure and lose cardiac output. So sometimes, for short periods of time, patients will be delivered high frequency ventilation if they are at risk to become hemodynamically unstable, or if they're at risk for pneumothorax, because we're going to talk about the complications in a little bit. You need to have sedation and paralysis when patients are receiving high frequency ventilation because it's really a lot of little breaths quickly, and the patients don't like it. It doesn't at all mimic normal breathing, and so patients often will resist this type of ventilatory support. So this chart here, you can see, okay, over here we have the patient breathing normally. They breathe in, they breathe out, they breathe in, they breathe out, okay? Right here we have assist control. So here we see a patient with a little teeny breath right here in the blue, and then as soon as they initiate breath, they get a great big bunch of air from the ventilator. They take a little teeny breath in, they get a whole bunch of breath here from the ventilator, okay? Where down here we have synchronized. So here we have a little teeny breath, okay, and it delivers a regular breath. And then we let the patient breathe on their own, okay, and then they have another supplemental breath, okay. So it's synchronized with the patient's breathing. It will only deliver a ventilated supported breath every so often, and it's, as you can see, it's much less frequently as a patient on assist control. So complete controlled ventilation delivers the most, followed by assist control, and then synchronized. This next thing up here is continuous positive airway pressure, or CPAP. Now, you've seen this in patients who use those apnea machines, the continuous positive pressure, usually at night, you know, those things that make them look like Hannibal Lecter. I have some pictures in here later on. Those are for patients who have sleep apnea. One thing we haven't talked about is PEEP. Okay, so you need to pay attention to this. So this is PEEP. It's a very cute name, but it stands for positive end expiratory pressure, and the name says it all. Positive end expiratory pressure. At the end of expiration, It delivers a positive pressure to inflate the alveoli a little bit longer than usual. And what that does is it allows the patient's alveoli to stay open, and it allows the oxygen flowing through the capillary beds to stay open and be exposed to that rich capillary blood um, longer. Okay, so it's positive pressure, so it can cause some trauma to the lungs. But the thing that you really have to watch out for is it makes the patient hemodynamically unstable. Their blood pressure will drop, their cardiac output will go down, and so that's something to consider. So sometimes we have patients whose respiratory status is so poor that they need this positive end expiratory pressure, but their blood pressure is also low, so you kind of have to weigh one against the other. Like, what do I want? Do I want to have their blood pressure drop, but have them well oxygenated? I mean, so there's drugs and other things. This is when we get into a lot of critical care things. A lot of manipulating a patient's blood pressures with medications, which is not in this lecture, and a couple of other ones, though. So these are just a comparison of the advantages and disadvantages of the ventilatory modes. So assist control, it takes over the work of breathing, so that can be good. However, we have the risk of hyperventilation and respiratory muscle atrophy because the patient doesn't really have to work terribly hard to keep the respiratory rate going. We have synchronized intermittent mandatory ventilation right here, and that prevents respiratory muscle atrophy and decreases the risk of hyperventilation, so you won't get that with SIMV, and you get better ventilation and perfusion distribution. However, it can be tiring for the patient, and so they might become too fatigued to keep this up. Okay. We have pressure supported. Okay, that improves the patient's ventilatory synchrony and prevents respiratory atrophy and helps with weaning. However, it requires spontaneous respiratory effort. So the patient has to be able to really kind of breathe on their own, and they can also become fatigued. Okay. And then we have pressure regulated controlled volume. And we don't see that too much, so I'm not going to go into it terribly much. One thing to consider is that we take care of patients, not the ventilator. So when the alarm goes off in the patient's room and you hear it, okay, everybody is heading towards that machine to look at it. If you cannot figure it out immediately, then what you need to do you need to take the patient off the ventilator and hand ventilate them with an ambu. So manually ventilate the patient. If you cannot figure out why the alarm is going, ventilate the patient, call respiratory, get them up there and let them help you figure out what's going on with that machine. One thing, these are initial ventilator settings. A couple of things that I need to mention is that the physician orders the ventilatory settings, so they will order how much oxygen the patient is to be on, what the tidal volume is, what the respiratory rate should be. They will order that. Anytime something is changed, you have to make sure that the change is okay for the patient. And the way you do that is you check arterial blood gases. So let's say, for example, you wanted to turn down the amount of oxygen the patient got from 50% to, say, 40%. Anytime you make a vent change, you need to get a set of gases. So what you would do is you would change it. You would wait 20 minutes to half an hour. You would get a set of blood gases. As soon as you got the results back, you would look at them and you'd be able to determine whether or not the vent setting should stay or whether the patient is doing better or worse. Can we continue to decrease the amount of oxygen that the patient is getting, or do we need to increase it? So it's determined by the physician, and the way you check if a ventilatory setting has been changed and it's okay is to do a set of arterial blood gases.